Hello, everyone. My name is Anthony Mato from Memorial Sloan Kettering Cancer Center. I've just come back from the ASH 2021 meeting, and I've had some really interesting presentations and updates. I'm pleased to be with Dr. Jennifer Woyach from The Ohio State University. And we had an updated presentation from one of the studies that you presented at the plenary session, actually a couple of years ago at the ASH meeting. And this is the randomized alliance trial looking at Ibrutinib plus or minus rituximab versus bendamustine rituximab. So everyone really paid attention to that. It was a big paper a few years ago. Can you update the audience about what you've learned with additional follow-up?
Absolutely. So we were very pleased to be able to present some longer-term follow-up of this study. And again, as you mentioned, this was a trial for previously untreated patients who were age 65 or older, and patients were randomized to bendamustine rituximab, Ibrutinib given alone, or Ibrutinib given in combination with rituximab. And so now we have up to 55 months median follow-up, and we can say again that both of the Ibrutinib-containing regimens were superior to the chemoimmunotherapy regimen, as we would expect. And still, there's no difference between patients who received Ibrutinib or Ibrutinib plus rituximab. So the rituximab does not seem to provide an advantage for progression-free survival in this case. So at 48 months, about 3/4 of patients who are treated with either Ibrutinib regimen remain in remission. 47% of those that were treated with bendamustine rituximab remain in remission. So the other thing that we looked at, which I think is really interesting, is whether some of our standard prognostic factors were able to predict those who were likely to have longer versus shorter remission durations on the Ibrutinib regimens. We showed this a little bit in our presentation, and there was a poster by Dr. Inye An, which looked at this as well in the context of the CLL-IPI, as well as the NHLBI's 4 score for Ibrutinib. The results of that were actually that some of our standard prognostic factors are not very good at predicting who is likely to have longer or shorter remission durations on Ibrutinib. But specifically, we found that 17p deletion or TP53 mutation, at least at this time frame, does not impact outcomes with Ibrutinib-based therapies. And so I think this is really important for those patients who have high genomic risk CLL at either diagnosis or at the time they start treatment, that specific prognostic factor can really be overcome by Ibrutinib-based regimens.
So I find oftentimes I have patients who come in to see me who have had FISH testing or IGHV testing. And of course, those reports automatically say, for IGHV unmutated, poor prognosis, or deletion 17p, poor prognosis. Just for patients, can you, go over a little bit about prognostic models and sort of how they're really relevant in the patient populations for which they've been developed, and maybe how should we be interpreting these reports in a time period where we have some of these newer therapies?
Yeah, so one of the things that I like to stress to patients is that right now, many of our prognostic factors are very good in somebody who's newly diagnosed to help determine whether they're likely to be in the group that is going to go many years before they need treatment or never need treatment, or somebody who's likely to need treatment more quickly. So we know that patients who have IGHV unmutated disease, those that have higher levels of beta-2 microglobulin, those that have abnormalities in TP53, their 17p deletion or TP53 mutation, all do have a shorter time to requiring treatment. And the CLL-IPI is a score, it's the CLL International Prognostic Index. It's a score, a calculator you can actually find online that takes into account a number of these prognostic factors and puts people into risk groups all the way from very high down to low risk. And that really can help somebody who's newly diagnosed understand, are they likely to need treatment in 2 years, or are they likely to not need treatment after 10 years? However, I think what's really exciting is that with our novel therapies at this point, once you get to the point of needing treatment, most of these don't matter that much. It may matter for some patients in which therapy you choose. So, for example, from some of the initial studies or the initial therapy studies, we see that IGHV mutational status and, like I mentioned, the TP53 abnormalities don't matter too much if you're going to be using a BTK inhibitor, or at least Ibrutinib. We know that patients treated with venetoclax obinutuzumab may have a shorter progression-free survival if they have a TP53 abnormality, and as well if they have IGHV unmutated disease, probably also have a shorter progression-free survival, though with that specific abnormality, it still is a very long progression-free survival. So I think that it's important to know these this risk status, especially early on in the disease course. But like I mentioned, once you get to the point of needing treatment, likely outcomes are going to be great regardless.
Thanks so much for sharing that. And the bottom line is this type of work is demonstrating we can overcome these poor risk features with newer therapies. Thanks again for updating that data set, and thanks for sharing this information today.